Okay. Good afternoon and welcome to this public meeting of the Standing Committee on Social Development. My name is Jane Wayallen Armstrong and I am the MLA for Mopi Clutha Region and Chair of the Standing Committee on Social Development. I will now ask members in the room and online to introduce themselves for the record, starting with Kieran.
Thank you, Madam Chair. Kieran Tester, member for Range Lake.
Julian Morse, member for Frame Lake.
Shauna Morgan, member for Yellowknife North.
And then virtual, starting with Cheryl.
Cheryl Yakala, a member for the Decho.
Danny McNeely, MLA for the Satu.
Okay, I will now ask.
Robert Hawkins, Nelly Yellowknife Center. Thank you. Good to be here.
Okay, that's it. Okay, thank you. Thank you, members. Today we are joined by the Minister of Health and Social Services, an official from the Department of Health and Social Services, to receive a briefing on systemic racism in the NWT healthcare systems, in the healthcare system. Please note this meeting is being live streamed to the Assembly social media channels. I would like to remind all members and witnesses to direct all questions and comments to myself as chair and to wait to be recognized before speaking to help us have a smooth meeting. I will now pass it over to the minister. And Minister, if you could please introduce your officials and proceed with the with the presentation. Thank you.
Good afternoon, Madam Chair and members of Standing Committee, and thank you for inviting me here today to discuss systemic racism in the healthcare system. With me today, I have online, I do believe, Joanne Chiquetto, Deputy Minister of Health and Social Services, Perry Heath, Assistant Deputy Minister, Corporate Service and Cultural Safety, Karen Blondin Hall, Director of Cultural Safety and Anti-Racism, Fraser Lenny, for the Northwest Territories Health and Social Services Authority, who is the Director of Quality Risk and Client Experience. And who else do I have? Tim Overview, Northwest Territories Health and Social Services Authority, Executive Director, Corporate and Support Services. And I do believe Ali Kincaid, my Ministerial Advisor, is there. Would you like me to continue on with opening remarks or?
Yes, please.
Okay. Thank you, Madam Chair. Over the last 10 years, the Department of Health and Social Services has worked to implement actions to support cultural safety and anti-racism. This critical work underpins everything the health and social service system is doing to redress the ongoing legacy of colonialism and anti-Indigenous racism that has so deeply impacted Indigenous communities. We recognize the urgency to address anti-Indigenous racism in the health and social services. To do that, all staff, including frontline service providers, need a foundational understanding of the ways in which anti-Indigenous racism manifests within the health and social service system to create inequities for Indigenous people. In addition to negatively impacting health directly, racism creates barriers that prevent Indigenous people from seeking care when needed. We have heard repeatedly from the communities that training service providers about cultural safety and anti-racism is essential. In 2018, the Department of Health and Social Services released a Cultural Safety Action Plan that publicly established commitments to address racism, systemic racism for Indigenous people accessing our programs and services. The broad objectives in this plan continue to guide the work of health and social services. Those objectives are to create an organizational culture of cultural safety, to strengthen staff capacity to deliver culturally safe care, to honor Indigenous knowledge and healing approaches in care, and to improve client and community experience. Since this action plan was released, there have been improvements within the department through the creation of a standalone cultural safety and anti-racism division and the rollout of the cultural safety and anti-racism training. This made the North training, this Made in the North training was designed by a team of Indigenous staff over 4 years who took a nothing about us without us approach, by piloting 13 different training sessions to health and social service staff. They created this visionary training through the guidance of Indigenous residents, knowledge holders, and the Leadership Council, as well as the Indigenous Advisory Body. Another significant advancement towards improving client and community care within our healthcare system is the addition of Indigenous patient advocates. As a regular MLA, I advanced this work with the support of my colleagues, and we now have 4 positions staffed in Yellowknife, Inuvik, Hay River, and Fort Smith, and are working with the Dehcho First Nations to staff a position to support the Dehcho communities. Through the Office of Client Experience, Indigenous patient advocates help Indigenous residents navigate health and social services system, address issues that may impact the care they receive, and connects clients and their families to cultural and community supports. Racism in the Northwest Territories is still blatantly obvious. As a department that creates programs and systems that care for all Northerners, we want to change and we want to make change. Today, we will speak to the reality of what takes place within our system. We will also discuss the great work that our teams are doing to address the racism that still exists within our system. It is important to note that while there have been recent stories that have been widely publicized and focused on specific incidences in which anti-Indigenous racism is being alleged, out of respect for health privacy as well as compliance with the requirements of the Health Information Act, neither I nor departmental staff are able to provide committee with any information or answers to any questions about the details of any individual patient's care. I wish to conclude my remarks by highlighting that this cultural safety is a key part of reconciliation between Indigenous and non-Indigenous people. As a department, we remain committed now more than ever to do our part. We want Indigenous people in our territory to enjoy physical, mental, emotional, and spiritual health and wellness. Thank you, Madam Chair.
Okay. So now with the presentation, so who's going to be doing it? Okay.
Okay, let's see. Myself and Fraser will be delivering the presentation. First of all, Masi Cho for inviting us to talk about our work, to brief you all. So for the first slide, please, it's just an outline. So we'll be going over background context, followed by the activities and initiatives, challenges and opportunities, and key learnings and next steps. Next slide, please. And next slide. So for background and context, as you can see here, there is an image of a tree. And a tree analogy is something we use a lot in our work to describe how racism is happening at different and multiple levels across the system. The roots represent the drivers of the different forms of racism that we are seeing within the healthcare system. The roots are the deep belief systems of white supremacy, colonialism, and racism that channel up through the trunk or institutions like healthcare to create race-based policies, practices, and norms, which then manifest as individual or interpersonal racism at the tree or the branch level, the leaf level, which directly impact patient care. So as you can see at the trunk, we have some examples of how racism is showing up within the institution. So here we see racism is condoned or allowed. There's an acceptance or normalization of substandard care, inadequate accountability measures to address complaints of racism, a lack of staff diversity, the dominance of biomedical or absence of Indigenous knowledge in healing, prevention, and care options. And Indigenous knowledge and care options are viewed as primitive, unwelcoming physical environments, policies and programs not informed by Indigenous community, and limited resource allocation to do this work. And at the individual and interpersonal level, we see racism showing up as bias, stereotypes, ignoring, delays, and denial of care, different or subpar treatment, inappropriate pain management, not believing patients, and disdain for cultural or Indigenous healing approaches. This analogy is also helpful because it points to the different kinds of work that we need to do to tackle the various forms of racism. And an example of this is that we are delivering our cultural safety and anti-racism training to health and social services staff and frontline workers, and we're targeting the individual level by offering that training. Most importantly, racism has its roots in hundreds of years of colonialism, racism, and white supremacy, and it will take leadership and action at all levels to dismantle it. Next slide, please. Okay. So a timeline of the cultural safety and anti-racism work at Health and Social Services is that the work began all the way back in 2013 with the creation of the Indigenous Health and Community Wellness Division. At that time, there was one position dedicated to cultural safety. And in the past 10 years, we have developed a commitment document to cultural safety titled Building a Culturally Respectful Health and Social Services System. We engaged with Indigenous partners and people to inform the Cultural Safety Action Plan released in 2019. We piloted the cultural safety and anti-racism training to inform our final training model. And we also established the Indigenous Advisory Body in 2018, and I'll talk a little bit more about them later. Between 2019 and 2023, we focused on designing and testing Made in the North by Indigenous Northerners initiatives to address anti-Indigenous racism. We also focused on growing our teams, such as establishing the Cultural Safety and Anti-Racism Division, the Office of Client Experience, and the Indigenous Patient Advocates, rolling out the new Cultural Safety and Anti-Racism Training Program, and completing action plan items. It is within this time frame that the first tangible work in anti-racism began, and we'll go over much of this work in the coming slides. From 2024 and beyond, our focus will continue on implementation, but also to learn, change, and adapt to these new initiatives based on critical feedback. This work is very new, it's never been done before, and we are learning as we go. Next slide, please. And the next slide. So getting into the initiatives, I'll start by talking about the cultural safety and anti-racism training. The aim is to ensure that all staff working within the NWT Health and Social Services system have the foundational knowledge, skills, and self-awareness to address anti-Indigenous racism and facilitate cultural safety for the Health and Social Services system. The training provides Health and Social Services staff with a common language and basis to understand the root causes of anti-Indigenous racism and to identify action required at individual and organizational levels to dismantle it. Next slide, please. So just a bit more information about the training. So our approach and some stats. We rolled out the training in 2020-21. This is considered mandatory training for all health and social services staff, with the exception of Indigenous staff. Because this training is about anti-Indigenous racism, we go over colonization, residential schools, and experiences of racism. So we want to give staff who actually experience racism themselves to opt out if it's triggering or they would not like to participate. And I will add that the online Living Well Together training modules are a prerequisite before they attend our training. The training, it has a max of 30 staff per session. We also have a team delivery approach. So basically, that's all hands on deck from my team. We're about a team of 8 right now. So more or less all of us are facilitating the training. It's also 2 days, it's in person. And we're delivering at this point almost every month, sometimes 2 times a month. It includes a mix of activities and guest speakers. We also have counseling support available because the training is triggering no matter who you are, whether you are an Indigenous person who experiences racism or if you're somebody who is actually thinking about how racism shows up in your work can be challenging. And since 2021-22, we've trained 600 individuals, and that's mostly health and social services staff, but it also includes deputy ministers and assistant deputy ministers who took our training last year, as well as 17 MLAs who took the training back in January. Next slide, please. Program planning and design. So this slide goes over the additional work that my team does in addition to offering the training. So first we have the Indigenous Advisory Body. This is comprised of Indigenous government appointees. They meet with health and social services staff 4 times a year to advise on Indigenous health, cultural safety, and Indigenous knowledge and healing related work. My team provides secretariat support, and we're also a standing agenda item. So every time we meet with the Indigenous Advisory Body, we are presenting updates to our work, we're presenting ideas about our work, and that we're receiving feedback constantly and getting their buy-in. The next piece of work is around developing cultural safety and anti-racism guiding principles. These were developed last year. They were approved by the Indigenous Advisory Body. We recognized as a team that we needed guiding principles to help with our decision-making and to root our work in an agreed set of ways related to cultural safety. There are 7 guiding principles in total, and a few examples include cultural safety addresses systemic racism, and by that we mean racism and colonization must be addressed to achieve Indigenous health and equity. Another one is strive for excellence as health and social services staff. And by this we mean Indigenous residents deserve the highest attainment of health and wellness, free of racism and discrimination. Therefore, we strive for the highest quality performance. Embrace humility. Commit to humility in all aspects of our work, including the relationships that we form. This involves self-reflection of the power and privilege we hold in relation to others. We seek and receive feedback with respect and gratitude. We also have a cultural safety and anti-racism tool in draft, and this supports wider health and social services staff capacity to apply cultural safety and anti-racism work. And this is beyond the advice that we provide other folks from across the system. So the tool provides reflection questions that stem from each of the guiding principles. The questions prompts the user to consider the context of the dominance of Western worldview, Indigenous self-determination, stereotypes and bias, and advancing equity. Staff can use this tool broadly from strategic planning to developing policy and standards. So an example of this is, so the guiding principle, cultural safety addresses systemic racism. A reflection question is, does your document or policy contain information about the historical or systemic context that results in Indigenous people being placed at a disadvantage? If not, what ways does excluding this information contribute to power imbalances and bias? Or the guiding principle, nothing about us without us asks, how did Indigenous people inform the development of this policy or program? We also receive requests from across health and social services to review their different documents. So some examples of a few that we've reviewed include the facility-based addiction treatment manual and community counseling program standard. And we actually use the cultural safety and anti-racism tool to review those 2 documents with the mental wellness and addictions recovery team. Some other examples include the blood transfusion information sheet for patients, the NWT health status chart book, the suicide prevention resources for the public, and we're also reviewing the NWT Wellness Courts program material for the Department of Justice. So we're doing some work outside of health and social services too. The evaluation of the training. So while providing education is an important tool in dismantling ignorance and changing racist beliefs, limited information is available about the extent to which a single training program alone leads to behavioral change and systemic change overall. In May, the Cultural Safety and Anti-Racism team began working with an evaluator to develop an evaluation framework to review the positive outcomes of the training, its limitations, and opportunities for growth. I also have listed commitment statements for job descriptions, and this work I am doing alongside my colleague from the Community Community Culture and Innovation Division to work with each division at the Department of Health and Social Services with directors and their staff to develop commitment statements to cultural safety that will go in every job description. And to do this work, we work with the teams to really unpack where systemic racism is showing up within their work. So we're working with each division, so that's mental wellness and addictions recovery. That's territorial health services and so on and so forth. And so by getting to understand where systemic racism is showing up in their work, we can then develop a commitment statement for how we're going to use cultural safety and anti-racism to address those issues. And then lastly, we are still working to finalize and complete outstanding cultural safety action plan items. So I've listed a few here, and they include developing updated patient rights and responsibilities, and I'm doing that work with Fraser, conducting an environmental scan on existing traditional healing practices and services in the NWT, facilitating a gathering of knowledge holders to develop strategies on ways to incorporate traditional healing practices alongside programs and services. Next slide, please.
Thank you, everyone. At the introduction, as mentioned, my name is Fraser, and I'm the Director for the Quality Risk and Client Experience Division. And I'm also the Program Supervisor for the new Office of Client Experience and the new Indigenous Patient Advocate Program. So it's really an honor to be here. So I just wanted to provide, I have 2 slides here just to give you some updates about the Office of Client Experience and what it is that we've seen in the first year of operations. So our first point here, first year at a glance. So I can honestly say the first year has been a really incredible journey for the advocates and myself and everyone on the team. I think we did take our time, but we were able to recruit talented and committed Indigenous staff who are now located in the territory's acute centers. The team had to really quickly organize once they were hired to brainstorm and develop an Indigenous design program that they felt would truly meet the needs of the residents that they were serving. So that was really amazing to watch people just organize and gather so quickly to create what we now call the Office of Client Experience. In the first year of operations, the team has supported over 1,000 clients and families from across the Northwest Territories. Of the near 1,000 clients, approximately 65% identified as either First Nation, Inuit, or Métis. Those numbers are really significant because that's who this program was designed to help. We wanted to be an inclusive program and serve all residents of the Northwest Territories, but it's specifically, we know the Indigenous population are going to be the people who have the most challenges accessing care and service from the system. And in the first year, we've had approximately 500 complaints in total, which I think is significant for the first year. The next point, the team is really committed to, is highly committed to meaningful impact. The team is very motivated to helping clients and families feel listened to, validated, and respected. The team is focused on hearing clients' stories, trying to capture them, and use these stories to help inform system change. And that's what we're trying to do, is create really good data so that way we can start to see themes and trends over the first year or over the next few years and find out, like, where is the majority of complaints coming in? Where do we need to focus our efforts as a system? The next bullet here, learning to support our people. So the concerns and challenges that affects residents who access care and service from our health and social services system can be vast and complex. The team has had to work hard in the first year to learn about the problems and barriers our residents face. With each concerns brought forward, the team has had to work hard to understand how the system works and if current policies or ways of doing business serves our clients. This has been a strong and ongoing learning in the first year, and it has enabled them to advocate in an effective manner. relationships and influence is our next point. So this team has developed and laid the foundation for meaningful and necessary relationships. These includes with clients, care providers, Indigenous governments, and organizations outside the NTHSSA. The advocates in our office have no authority, and that's really important to highlight. So we really do rely on relationships with others to influence and drive change and support our clients. I can honestly say that in my experience, our team has really aimed to provide client and family-centered care. And I think that just means really taking the time to hear people and hear their story and make sure that they feel validated and that they feel listened to. The last update I want to provide is on survey data. So a survey is sent to each client and family member who accesses our services and who files a complaint. To date, survey data has indicated that clients who have accessed the Office of Client Experience feel listened to, respected, and culturally safe. This is a true measure of the team's success. What is not a measure of success for this team is to find a solution to every concern and to fix system issues. This is the system's responsibility, and we have to inform the system of what we are hearing, and they need to listen and to act. Next slide. Okay, so the next slide focuses on what we know, and this was challenging because we've learned so much in our first year of operations. But these are some of the highlights the team wanted to share with the committee here today. So the Office of Client Experience staff manage events of institutional and interpersonal anti-Indigenous racism across the health and social services system. This has become very apparent in the first year of operations. This racism would have likely gone unnoticed without the team's involvement. The team has worked hard to address these concerns and resolve them in a meaningful way. The second thing we know is that clients know what's best for them. Clients and families know what is best for them, what a meaningful resolution might be, and what supports they need to address their challenges or access care in a safe manner. This is one of our guiding principles and one that lays the foundation in our work every day. System support is crucial. So in order for this office to support residents, all levels of the health and social services system, including our senior leadership, need to support this program and its mandate. Community partnerships and having Indigenous leadership can expedite meaningful change. A step towards ending systemic racism and daily discrimination targeting Indigenous people in the healthcare system is to focus on inclusion and respect. We can move forward by building long-term relationships with Indigenous communities and recruiting and promoting more Indigenous leaders in our healthcare system. The last comment I want to just make, and I think it's really important to highlight here, is that Indigenous language support is a challenge in our system. Language supports are not always readily available throughout many Indigenous clients' care journey. This includes from when they begin their care journey until the end, including when on medical travel. The system is very reliant on family members for interpretation, and this is not always ideal. An example is when informed consent is required for medical treatment and procedures, and family members are not trained in medical terminology. We also know that Indigenous clients are refused escorts for interpretation when on medical travel. There is no standardized way to access language supports when needed throughout the client's care journey. And my last point that I want to comment on here is that when harm happens, we need to do better in supporting our clients and families. Current processes to review and address client harm do not put the client in the center, and more needs to be done to aid in meaningful reconciliation.
Okay, so moving on to challenges and opportunities. Next slide, please. So the challenges first. The folks, the teams that are leading this work, the teams are small and mostly Indigenous, which is also a great thing. For the Cultural Safety and Anti-Racism Division, there are 10 positions in the division. 8 are currently filled. 7 positions are indeterminate and 3 are term. 7 of the 8 filled positions are Indigenous.
Right here. Yeah. Just speaking about the Office of Client Experience, so we currently have 8 positions filled, 4 advocate positions filled indeterminately. As was mentioned earlier, we're working to staff a new position in the Decho and Fort Simpson. So 5 positions within the Office of Client Experience are core funded. We don't have any indeterminate advocate positions for the Satu, the Clecho, the Decho, and the Yellowknife regions.
Another challenge that we are experiencing from the Cultural Safety and Anti-Racism Division is that we are dealing with frequent resistance to addressing racism. Is high emotional labor for cultural safety and anti-racism program leads and staff. Facilitating anti-racism transformation is a specialized skill set with no others in the NWT doing this work. There is no guidebook for how to do this, and we are learning as we go. We are finding that the work is especially taxing and at times harmful when the training staff, who are majority Indigenous, are frequently exposed to and expected to respond to white participants' denial of racism and the ongoing blatant racist beliefs without proper training and time to work through these experiences as we deliver the training. We are still learning how to build, make adjustments, and make time for those adjustments and deliver this training without burning Indigenous staff out and protecting them from the very racism we are trying to eliminate for Indigenous patients. The other point is around reliance on temporary and third-party funding. Much of the recent growth in position to lead this work has been initiated through federal and third-party funding. The vulnerability of these programs and units are susceptible to changes in funding. For the Cultural Safety and Anti-Racism Division, there is no O&M core funding, and only 3 of 10 positions are core funded. The new and existing structures, such as the Indigenous Advisory Body, Indigenous Client Experience Council, and the Cultural Safety and Anti-Racism Training, require high levels of administrative and planning support. So for my team, we're a small team and delivering the training almost monthly, and 4 Indigenous Advisory Body meetings requires all team members to support, and so it is very admin heavy and pulls us away from the other important work that we could be doing. And finally, as mentioned before, addressing systemic racism requires a culture shift and action at all levels, and leadership buy-in, and more than just 2 divisions doing this work, I think. Next slide, please. So opportunities, I'll pass it to Fraser to go over the first 2.
Thanks, Karen. So one of our first opportunities that we've been discussing with the Office of Client Experience and Cultural Safety and Anti-Racism Division is that we have a real opportunity to leverage data and client experience just based on the work that we're seeing and working with clients every day. We really need to take a moment and time to review the data that's coming in and really see how we can use this data to inform system change. The next opportunity includes the HSO, it stands for Health System Organization, Cultural Safety and Humility Standards. So out of the In Plain Sight report in British Columbia, HSO partnered with Indigenous governments to create new cultural safety and humility standards, which is essentially used as a tool for healthcare organizations to assess themselves, similar to an accreditation standard, to say how, as an organization, are we applying ourselves or working to improve cultural safety throughout the system. So this is actually really exciting. So Accreditation Canada is now partnering with HSO because these standards were specifically designed for British Columbia. There's a definite recognized need to develop standards that can be used across the country. And so organizations who are assessed with Accreditation Canada, so can subscribe to this standard. So that's work that's in progress, and I've been trying to keep an eye on where that is. And organizations have been encouraged to use the current BC standard to start the work and assess and see where we are, in anticipation for when this new national standard comes out. So that's really exciting.
And I would say another opportunity is around the team's commitment to addressing systemic racism. I think because this work is so challenging and emotional, you have to really love and feel passionate about this work. And not only that, but over the last 3 years, especially since we've been delivering the training, we've developed a lot of skill. We've tested a lot of different things. While we do need training, we've developed a lot of skill set over the last few years to address systemic racism. Some other opportunities include anti-racism facilitation training, and we know that we need to make the proper investments into staff by prioritizing learning, training, and allowing time to make critical improvements. We recently participated in an anti-racism facilitation training for the first time in May, and we plan to continue our learning and coaching with a diversity and inclusion organization that specializes in this work. And I think this will make our training, the cultural safety training, and the work overall sustainable. There's an innovative approach to primary healthcare reform by centering cultural safety and anti-racism, and planning to understand and identify the steps necessary to take a whole of government approach to cultural safety and anti-racism.
Okay, next slide, please. So the next steps. So just going back to the sort of analogy about the tree and the trunk and the roots. So the next steps when it comes to dig up the roots is that patience and time for the system to learn and change is needed. We do have to strengthen the trunk. We have to build momentum for policy and program changes based on feedback, and then we have to grow. We have to expand training for staff with resources and additional access to patient supports and advocacy. As we reflect on the first slide on this presentation, with all that was shared today, we need to address the fundamental issues at the root of our healthcare system. This involves a deep, honest look at our current practices and acknowledging where we've fallen short, in some cases, in providing culturally safe care. It's important to remember that meaningful change takes place. We must be patient and allow the system the necessary time to learn and evolve. We need to focus on strengthening our core at the trunk level. This involves using the insights and feedback we've gathered from patients, staff, and the community to inform and drive our policy and program changes. This feedback is crucial as it provides real perspectives on what changes to policies and programs are needed to be responsive to residents' needs, but also be sustainable. Lastly, we need to expand our training programs with adequate resources to ensure that all staff are equipped with the knowledge and skills necessary to provide culturally safe care, while increasing access to patient support and advocacy services, ensuring that patients have the resources they need to navigate the healthcare system effectively and have their voices heard. This process is not about quick fixes, but about fostering a long-term commitment to understanding and addressing systemic racism within our healthcare system at all levels, from the leaves to the roots. We must be willing to invest time and resources into this foundational stage. Okay.
Thank you for the presentation. I will now ask the member if they have any questions. MLA to start.
Thank you, Madam Chair. Thank you for the presentation. I was one of the MLAs who attended the cultural safety training, and it was I think a very informative, eye-opening experience. I think we have a very good program here and very good staff who are delivering it. I think they've been recognized for that achievement as well. And it's got to be difficult with such a small team, so I do appreciate how challenging this enterprise is and that it is a systemic problem that requires a systemic solution, not quick fixes. So I agree with that wholeheartedly. I think the issue we have is making sure that this large project that is a multi-year, if not multi-generational exercise, is on the right track, and that we can start to see the fruits of this labor and enjoy them quickly. And in particular, those who need healthcare services and support have access to it as quickly as possible. But when there is a problem, and a high-profile problem, we do have a quick fix to that incident. And I know we're not talking about specific incidents today, but I think we can talk about how the system responds to specific incidents. So when there is an incident of systemic racism, how does the system respond currently? Could you walk us through those steps? Like once the healthcare system becomes aware of something, what steps do you take to address it, like to understand it, to address it, to resolve it, and what kind of timelines and like concrete steps come out of that? Thank you.
Okay. Minister, do you want to respond to the questions first, or we'll go on to the presenters? Thank you.
Thank you, Madam Chair. Madam Chair, I would have Mr. Lenny take this one, and if the Deputy Minister needs to add to it, because I think the first step would be through the quality risk area. So I would pass that to Mr. Lenny.
Okay, Mr. Fraser.
Okay, Chair. Thank you for the question. That's a really great question. So when allegations of patient harm come forward, we do have a quality assurance process that we use within the NTH-SSA to review patient incidents. And one of the questions, whenever there's harm or maybe there's specific allegations of racism, of course, is to ask ourselves, like, the question, is this person Indigenous? And just by asking that question, that's a step for people, because in my experience, since I've been in this position, sometimes that question isn't always asked. And what we do when we have an allegation of interpersonal racism is we work with the client to really try to understand and to hear their story. That's when they get in touch with our office and with the advocates, that's a really big step for them if they feel that they've, been traumatized or received harm from the system. And what we do is we try to hear them and we try to validate them and really try to understand their story. And it's really important that we let the client be the expert, because the client knows what they need. They know what a resolution might look for them. And so the advocates don't go in, we come up with suggestions or options, but it's really, when we talk about meaningful reconciliation, it's really taking the time to say it's a healing journey for people, saying, like, what do you need in this very moment? I can understand maybe you've experienced trauma. Do you need support? Do you need time? What does a resolution look like to you that you can walk away from this experience feeling like you've been heard and your concerns have been addressed? And our approach has been very different, I think, in the past. Like typically when we've received a lot of complaints in the past, from my experience working for the system, we'll take them, we'll hear their story and we'll take things away and then we come back to them. But there's that whole putting the client in the center piece that was missing. So when we truly try to take direction from the clients to find, what it is that they need. And this has been a big change for the system because they're not used to that. They're not used to us supporting clients. Perhaps the client wants, they felt dismissed by someone. Maybe they want to talk to that physician or that nurse or that healthcare provider that they felt somehow wronged them or made them feel a certain way. That's a new way of addressing concerns within the healthcare system. And sometimes these things can take months, right, until the client is ready and they're at that point in their healing journey where we can address things in a meaningful way. So there's lots of nuances, and it's different with every client, but this has been our approach with every concern that we get.
Thank you. Deputy.
Thank you. Can you hear me okay?
Yeah.
Great. I just wanted to add just a couple of points. We do have, should we have a situation whereby we feel there is a need for an investigation, we do have critical incident guidelines that we have in place for investigations whereby there is a neutral party that actually does an investigation, and that's actually under the authority of the minister. And the report, that process is, of course, a confidential process whereby there are usually at least two investigators that are assigned to the file, who would not know necessarily, would be neutral parties who would not know the clients that are involved or the situation that has occurred. And then they go through their investigation process, and in the end, they provide a report back to the minister. And typically there are recommendations that come from that. And in fact, I can tell you that much of the work that we have done in the health and social services system, particularly around the pieces that Ms. Blondin Hall spoke to around our training, actually came from an investigation that we did within the health and social services system that was approximately in 2015 and 2016. And from that investigation, it was identified that staff required formal training around cultural safety and anti-racism, that we needed to formalize the process for investigations. And so some of the great work that actually was shared today actually stemmed from a critical incident investigation that happened, as I said, back in 2015, 2016.
Okay. MLA, to start, do you have a follow-up?
Yes, thank you. Thank you for that response. And that case, I think, is well known to people who were paying attention at the time. And I was at MLA at the time. So I've seen this work kind of get started. And it's impressive to see how far it's come. My concern I do have, though, is as so much of our healthcare system is dependent on locums and people who are not resident or permanent employees of the healthcare system, they don't have the same access to training opportunities. I've heard this as well, that this is not the case, especially around healthcare agencies and other kind of stopgap measures we put in place to ensure systems sustainability, in particular in small communities. So if you have that situation where you have people kind of coming into a community, how do you ensure that they're properly trained or that they have access to the anti-racism training? When you're such a small team, your resources are limited, then we already are experiencing staffing challenges to just provide basic medical service. I want to ensure that everyone who's providing healthcare in the Northwest Territories has the same training and opportunity for training. So could you just speak to that issue? Thank you.
Thank you. Mr. Lenny?
No. Chair.
Okay.
Hello?
Yes, go ahead.
Oh,
please.
Okay. No, one of the issues that we, like MLA Test Start has, this is not a new issue. I mean, I think when I look back at the training that we did where we were providing back when I was, hiring frontline staff as well in my old role, that there is an expectation that this training was to be taken prior to commencing the start of their work. I know that the training has now evolved, and it's a longer module there. It is online, and so that expectation is still there for locum staff to be taking this online training prior to commencing their employment. But I can pass that on to either Karen or Tim, whoever can answer how that we track this now with our locum staff, and what the expectation is with hiring of locum staff that we do have that are we are dependent on in providing healthcare in our system.
Okay, Tim?
Thank you, Madam Chair. And thank you for the MLA for the question. I think the MLA's hit on a key concern across the organization, specifically in the last several years with the way that we've had to adjust to different staffing models for continuing operations. Right now, we focus on some of the core training that has to be available for our staff coming in. And majority of that doesn't give enough time for those individuals to take some of the longer term training that was discussed in this meeting here. So there's two actions that would have been reflected in the presentations. One is ensuring that more and more staff across the organization that are here possibly multiple times. So we're really encouraging, part of our staffing strategies is to have people return to the north to take on similar positions. So that gives them more time to not only continue their onboarding, continue their training. And then also you heard of Karen, some of the length of time it took to develop the training that it is today. And I believe in the next phase of some of that training is to look how we can have it applied to that transient workforce that does come in, and looking at options to adjust the model of training and to take some of the good learnings that we've had out of the current training today. But I think the more important part is to reflect on, as more people become aware across the organization around cultural sensitivity, cultural awareness, we can become allies for individuals in our organization on a regular basis. And I think as allies, that doesn't mean that every single person has to have the same training. That means that people feel free to identify where they see issues, have conversations with colleagues, or encourage colleagues to be trained, to be aware of some of the differences we have in working with clients and patients across the NWT as well too. So again, as the MLA mentioned, this will be probably generational work. And I think the short answer to it is trying to adapt our current training modules to see where there's ability to amend them into a place where it can be reflective of the current staffing models that we have coming in, the people coming into the organization, possibly for shorter periods of time. But again, those are likely going to be learnings coming out of the current training that we have too. Thank you.
Am I late to start?
Thank you, Madam Chair. Just one last one quickly. Is it possible to develop some sort of certification system or program where you could take the training, get a certificate that shows that you've done this, especially after the new standards come in place, that would incentivize the transient workforce to take it? So like if you're here and you take the training, it's easier for you to get placed in other systems or in this system. So there's an advantage to it. Sometimes incentives are the best way to do things rather than creating new requirements. So is that something that could be looked at? Thank you.
Okay, Minister Semler?
Yes, and I think any type of feedback that, MLAs might have on this, and I know that with any of our training that we do have, there is a current, like a lot of the training within the health system, there are, some things have to be done annually, some, follow up, some, and this is one that, if you've taken it and you've got the certificate, it's on your HR file, it makes it a lot easier for those staff. And, and I mean, as a past manager myself, bringing in staff, if we had to bring in a term that comes back or a job share, it's a lot easier. They can go right to work. There's no, you don't have to onboard again and again and again. So, we'll take that back and, and we can provide all of the things that, we do currently and things that we can, any feedback that we do that we could make changes to providing that. Thank you.
Thank you. MLA Morgan?
Thank you, Madam Chair, and thanks for this presentation and for the team coming today. I had a follow-up question from the previous answer to MLA Testar's question about how does it work, how does the system work if there's a incident or a harm done to a patient. So Mr. Lenny described like a quality assurance process where you're trying to put the patient in the center and it sounds like have in some cases like alternative dispute resolution processes or some kind of resolution. But then the Deputy Minister described the critical incident guidelines process and a third party leading an investigation. So I was confused whether those are two separate processes or that they're somehow layered on top of each other, or it's happening at the same time, or it's done differently in different situations. Can you just explain how those two things that you described fit together? Thanks.
First, I would like to put this question to Minister Sendler, and then we'll go from there. Thank you.
Thank you, Madam Chair. Just so I want to be able to provide for more questions. I'll give this to the Deputy Minister who can clarify the two different scenarios. Thank you.
Deputy Minister?
Thank you, Madam Chair, and thank you, Minister, as well. First, I would answer is that it really depends on the nature of the situation. There are times where, as Mr. Lenny had noted, that there are times where the quality assurance process may or may not be all that is needed. There are incidences that actually jump right into a critical incident investigation because of the nature of the incidents. What I will share with you is that we were developing the quality assurance process for the system, which is what Mr. Lenny spoke to, and the critical incident investigation guidelines pretty much at the same time. And the intent is that there would not be overlap and that there also would not be gaps in this process. So I don't expect you to remember this, but in our business plan, we do talk about the need to update our critical incident investigation guidelines. And it's for this very reason, because there are times when one or the other may be needed, and there's times where one leads to the other. The other piece that I did not mention, and I want to be mindful of this, is that anybody can file a complaint for any reason, and they can also file a complaint with a professional body. So if it was a concern about an individual's practice, say it was a nurse, they would file that complaint with the College and Associations for Nurses for the Northwest Territories and Nunavut. Physicians, for example, that would come through the Department of Health and Social Services. So in short, they are separate processes, but the intent would be that there would be continuity between the two of those. So hence the reason for us to go back and revisit our processes.
Thank you. Mr. Lenny, you want to answer that as well?
Do you want a response from me as well? Okay. Yeah, like it really depends on, what's happened to a client. We have critical incident guidelines and we have a quality assurance process. And so when something happens in the system, there's multiple things that can sort of happen at the same time, different parallel processes. So for an example, just off the offshoot, when something happens, we typically do what's called a preliminary review. And so we try to determine, and gather the facts around a situation. And based on that information, we have reviewers who will make recommendations on next steps. And so some of those recommendations, you know, there could be parallel, there's different avenues that we could choose. So an example, one would be a quality assurance review, which is protected under the Evidence Act. Another one there's critical incident guidelines. So we're always wondering, did a critical incident occur? Does this meet, based on what we know so far, does this meet the definition of a potential critical incident? Because then we can go down that pathway. And we can also determine things like, was this an occupational health and safety event? Do we need to loop in OH&S, or was this a human resource issue? Blatant. So several recommendations are made based on the initial preliminary review. And so depending, you know, and each of those different types of reviews or avenues have different ways in which we can move forward. So I hope that answers your question.
Okay. MLA Morgan?
Yeah, thank you very much. So that does help to explain it, and it does seem that it's still a work in progress to figure out exactly how everything fits together. So that's good to know too. Do any outcomes of this become public, or at what points in this can either MLAs or the public in general sort of hold the system accountable to, like, what have we learned? What are the outcomes? You know, the Deputy Minister said that there's typically recommendations that come out of it. How do, you know, the rest of us see what is being recommended and what's being accomplished here?
Okay. Minister Simler?
Yes, and so with this, whenever there's an investigation, you know, depending on how it came into the system, still all of it is done confidentially, because it involves health information. How it's reported, you know, with the recommendations, any recommendations, on any investigations are made public and usually are provided on our website. And I know that in the past, you know, Mr. Testart, you know, said that we all can, if we were all paying attention a few years back, a few governments back, this is the root of where this department has been created from, as from recommendations. So if there's anything that I've missed in that, I'll pass it to the Deputy Minister for anything that she can add.
Deputy Minister?
Thank you, Madam Chair. I would just reconfirm that the Minister is correct. The critical incident investigation recommendations are public. We do have those on our website. And in fact, the previous recommendations from previous situations, updates on those recommendations are also on our website as well. And we tend to update those at a minimum on an annual basis. Thank you.
Okay, next, George, MLA Nersu, a committee member. Thank you.
Thank you, Madam Chair. Thank you for the presentation.
Okay, yeah, proceed.
Yeah, just on a few incidents that I was made aware of in the past in regards to being diagnosed, and the patient wasn't feeling comfortable with the diagnosis. And this, I know of a particular patient that at his own expense went to a different jurisdiction and received a different diagnosis from there. And when he got the results, it was deemed too late. And when he came back home, he informed his family of what what the results were, and it wasn't good, and he didn't last very long. and the family was at a stalemate on what they can do, or even if there's anything they can do in that matter. Instead of going to another jurisdiction, is the department able to, if the patient requests a second diagnosed medical opinion within our jurisdiction, will the department be able to assist them in that matter? Or because this particular incident, or whatever you want to call it, was they weren't given an option of going for a second medical opinion, so he took it on his own to go to another jurisdiction, get a different medical opinion. So would they be able, how would they be able to go about getting a second opinion? Because in my own opinion, I feel they weren't given a fair diagnosis, or they were saying, sort of, I can see racism in this particular field here, because they were just using the colonialism of saying, no is no, and they've taken that for years. And I just want to know if the department will be able to assist them in obtaining another, a different a second medical opinion if they're not comfortable. Thank you.
Minister Simler?
Yes, and and this what MLA Narasu is saying is not something that, it's not a new, we've heard this before. I have always said that, we know that there's issues, we know that there's concerns, we've heard this from people before, and that is why it's important that when people are feeling that they're not being heard, that's the patient advocates are available. Doesn't it's just because you're not in one of the regional centers, there is the number, and we've provided that to all of the MLA's offices to put that out into their community, to have their constituency assistants, making sure that patients are aware that they have rights, that they can talk to inpatient advocates. So that patient advocate sometimes will be someone who they may be able to reach out to if they're not comfortable reaching out to the physician or to speak to the nurses in the health center, if that's the general feeling that they're having. And it's not to say that they're so that's one of the areas where I feel that we have done a lot of work on, and we've made other avenues for support, for advocacy, for Indigenous people, and not just Indigenous people, any people who are feeling that they're not getting the answer that they feel like they want, or they need a second opinion. That is okay to ask for, and that's something that the anybody should, can and should do. Is I'll just pass it over to the Deputy Minister if there's anything that I've missed, that we do have for people to be able to do that.
Deputy Minister?
Thank you, Madam Chair. I would just echo what the Minister has said. This is something that is available. A second opinion is an option for our clients. What's key there, of course, is the client to ask for this, or their guardian, for example, or if they're even an adult that is in the care, that is has a guardian, another adult that is responsible for their care, as an example, if it's an elder or an adult family member that one of their children sometimes has that guardianship. I know it can be intimidating to ask that question of the practitioner that they just got the diagnosis from. So as Minister has noted, they can go to the patient advocates there's other avenues whereby we can help facilitate that for them. So, but ultimately that needs to come from the client or their family who's responsible for their care to be able to ask for that situation. Otherwise, we would not know that a second opinion would be needed.
Okay, thank you. Thank you, Deputy Minister. Tim, would you like to answer that as well?
Thanks, Madam Chair. And just to clarify as well, from the quality assurance process, there's really 4 major steps. There's the identification, there's a review of the event, there's a disclosure, meaning sharing something back to the client and the patient, and then some learning for the organization. Those are kind of the generic steps in our quality assurance processes. And the intersection with the Office of Client Experience and the Indigenous Patient Advocates really is in each of those steps. So they're there to help identify and help support clients and patients to identify where they think is harm. So in the case examples that we were just discussing, this would be a perfect opportunity, as the Minister and the Deputy Minister flagged, is having the Indigenous Patient Advocate available to that client or patient to help navigate how to express their concern of what's happened. And then there could be several solutions that come to fruit. And as Fraser mentioned earlier, one of the key things that his team is doing is actually asking the individual what is a resolution for them. And I think we've been surprised in a lot of cases. A lot of people sometimes don't want anything. They just want to be heard. They want to share this for future learning. And that is a good indicator for us as well, too, is when we talk about putting the client or the patient into center of that review, is asking them first what a resolution is for them. We still may need to do a bunch of those steps so that we can learn as a system, but at the very least we're concentrating on what is a resolution for that individual. Not all the time can we get them the resolution that they want, but at least we can listen and hear and try to advocate for that. And part of the disclosure as well, too, as Fraser mentioned earlier in his presentation, is trying to find ways where we can disclose more information quicker to individuals so they can be aware of the process that's happening that they may not be acutely tied into. And those are the changes that the Deputy Minister flagged around the intersection of our quality assurance activities, the learnings that we've had over the last several years and the feedback, and how that might apply to changes to the critical incident guidelines and other processes as well, too. So we're excited about some of the feedback that Karen's team's bringing, that Fraser's teams are bringing, that might actually start to fix some of those changes we see at the trunk of that tree that we talked about earlier, where we can actually see some changes in our quality assurance processes and possibly even our critical guideline processes to allow individuals to be aware of what's happening with the concerns that they had about their care as they move forward. Thank you.
Thank you. MLA Nurse, do you have a follow-up?
Okay. Thank you, Madam Chair. My second inquiry is about Indigenous languages. He stated that it's very difficult to support is not always readily available. A few years ago, I went south to Edmonton and I stayed at the Larga facility. And there was an elderly lady from, I believe she was from the Satu. And she was sitting in the backyard. She could barely speak English. She must have been in her 70s or 80s. I was there on medical too, and she was crying in the backyard because she just lost her grandchild to cancer, and there was no advocate there to help her on what the process was. What should she do? How will she get her child home? And I went out and she was crying, and I didn't know what to say, but what little English she said her granddaughter's gone. I thought she meant she went someplace in the city or someplace, but she said cancer, and she didn't know the process of what to do or where to go or who even to ask. And today you still see this, I still see it and hear it from my constituencies saying that they're not given the opportunity to have a person go with an elder. You send an elder down into a concrete jungle and expect them to survive, because I've always stated that, we've been taught just to say yes to anything. And we have to, I want to see this stopped, you know. And I believe, and I truly believe that language is a barrier. And I hope, you know, like you said, it is trying to be addressed, but it is still hard to hear that people are being sent without escorts. Escorts is the biggest problem within our medical system, I believe. Medical travel, you know, you're sending people down to Yellowknife who haven't even been on a plane before. And my question is, you know, I know you're with this group, you're really trying to address all these concerns, and I hope that language is one of the biggest concerns that you're hearing, that you're addressing, and is it being addressed at the community level where most of the concerns are coming from? Thank you, Madam Chair.
Minister Simler?
Yes, and thank you for that, George, MLA Nersu. I think that's one of the, you know, I've been on the other side of the house. I've raised the issue. There are things that we have in place, and you know, the thing that we seem not to be able to do well, and in the way that we have technology now, we don't get the information out. So like with supports, like what's the information that people need when they're traveling? If there's something, you know, we have contracts like with Larga in Edmonton, but those staff are there to provide them with a certain level of service. It's not the service that you're describing. It's, you know, we have the same thing with Kaskori. We have a contract with them in Yellowknife, and their service is to provide boarding and meals. And then we have the escort, you know, the non-medical escort issue. And so if they meet the criteria, but yet our criteria is something that we need to be reviewing, because I know that we've heard it many times, and I'll be honest, you know, I'm pretty good at navigating the system, but my own self going into from the north and, you know, navigating a hospital like Inuvik, even going into Stanton is a bit much. And then walking into the U of A, and, you know, coming from a community that's smaller than the amount of people and the footprint of the U of A, it is something that we need to look at, because that's intimidating on itself, and that can impact care. And so we have to be looking at these things, and that is why one of the areas of the, you know, of the business plan and the priorities is highlighted specifically an overview and review of medical travel and how we provide, and that includes how we provide non-medical escorts and who's, you know, the criteria, amending that criteria. Not every senior or elder needs an escort, and, you know, there are some that will say, I don't need an escort and I'm fine with navigating the system myself. But the ones that we do, we need to ensure that they are getting the services that they need. And so as of we say right now, like, you know, whenever we get those one-offs, if it's a senior, and, you know, we've had MLAs that, you know, there's a senior that doesn't speak English. Yes, we've dealt with it, you know. And then there's the scenario, but every case, it seems like we shouldn't have to be dealing by one case at a time. And it shouldn't have to come through the minister's office or, you know, through the MLA's office. We should just have a process that we know when circumstances are this, A, B, or C, then they get an escort, you know, a non-medical escort to accompany them. But then we also operate within a multi-system. And so if those escorts are approved by NIHB on an exception base, those are removed from our jurisdiction to approve. And so that's, you know, that's another, I think that's something that we need to also, with all the work that we're doing with non-insured health benefits, that's something that we need to clarify when we're collaborating, because with the two-tier system, you know, when you got our system that we have a medical travel policy, And then we have non-insured health benefits that also includes medical travel for exception base, then and then, you know, and that's the thing is our staff are left, the ones that are in the office being asked why, but the actual decision is not being made there. So I can pass it on to Tim if there's anything that he can add to that.
Tim?
Thank you, Madam Chair, and thank you, Minister. I think I'll just add to reflect back on the presentation. One of the key activities that Karen spoke about was program planning and design. And this is an area where continual feedback from within the organizations and the system is going to be integral to advance some of these changes to contracts, changes to policy, changes to processes. And medical travel administration is a key topic and is a priority, as you've seen through the business plan and through other mandates as well too. And the way that this is being amplified with the current structures that you heard here today is a lot of the Indigenous patient advocates and the Office of Client Experience have done visits to different facilities, have looked at the process of medical travel and have started to provide advice. And I think that is a really key aspect of how we are shifting in the slide deck you saw 2024 and beyond, is starting to use that voice and starting to use that feedback as we apply it to new contracts, to do changes, to do policy. And that is a big step for the organization to actually start to use that voice that's being driven by the client, being received from Indigenous employees, Indigenous leaders, and then being applied to organizational policy, organizational processes, and possibly some of our updated contracts as we go forward. So I think it's an exciting time. I also think this is a huge challenge because of the many intersections that the minister spoke about. But this is one area that I think we can actually make some real difference over the coming years in this assembly as well too as we move forward.
Okay, thank you. I would like to ask MLA McNeely if he has any questions, or MLA Yakalaya. Thank you.
Yes, thanks, Madam Chair. Could you hear me?
Yep.
Yes, we can hear
Thank
you.
you. Yeah, I've been having a very troubling, I would say, 10 days or 11 days. I can't recall here. I just know that we finished session on the 13th, and it's just been turmoil after another in a situation where it's so isolated. It's just beyond belief. And above all, the drug issues, the poverty issues, the lack of work opportunity issues, delayed projects because we got a cancellation to our barge, and the fire evacuees coming in here and needing assistance, and only to find out this morning that World Fuel is the agent for Avgas up at the airport. So they're going to fly in Jet A fuel, and it's going to go up by $1 a liter. It's currently $2.25 a liter. So you can say 30% or 30 points is going to be the new cost of living here, because everything is going to be flying in. Even the other day at the airport, I seen Buffalo Airways, this new 737 jet, transporting drum fuel and red fire retardant totes. So now the cost of this fire in Fort Good Hope is going to escalate by how much, I don't know. So everything from your sugar to your flour to your fire retardant is all flowing in.
What is your questions? Racism within the healthcare system.
Well, my question is, I think the SAW2 really needs some attention here, and I think if we live in this anti-poverty world, I think my suggestion is to have Health and Social Services Conference here in the Sawtoo.
Okay, Minister Semler?
Thank you, Madam Chair. I hear the frustration coming from the MLA from the Sawtoo. He's got a lot going on in his riding right now, and you know I'm always committed to working with the member on if there's leadership that need to discuss. Last week we meet as cabinet. We meet with the Indigenous governments and with the with leadership. Even with the MLA. He's been very good at working with cabinet and bringing the issues forward, and so I continue. As for any type of meetings that if he wants, if there's constituency, if he wants to have staff from the department and myself to come in and meet with him on his constituents, I'm always willing to do that with the member. And I'll just leave it at that, Madam Chair.
Okay. MLA McNeely, do you have a follow-up?
Yeah, my follow-up, and I thank the minister for that invitation. And, I'm just trying to visualize and put the concerns that I've been hearing from hundreds of people is that people want answers. We are getting answers at this table. But the people out there aren't getting the answers. And at a conference, they will get answers. And I think they will respect the advocacy group that I really see as a huge value to the system of mitigating client experience advocacy representation. And that's what people want to hear. If I went downtown and I asked somebody, okay, do you know what the advocacy group is? They will probably say no, because the messages aren't really going to the people that matter. Yes, you might have a bilateral meeting here last week or this coming week, but I'll give you another example. So I asked, I know the last assembly on the 26th of April, 2023 had a meeting with cabinet like they do with SSI. Medical travel was on the agenda. I heard nothing about medical travel concerns throughout my campaign. And in November, I'm downtown Culver Lake. And so I phoned one of the staff members of SSI. I said, what have you guys done to address medical travel since your last bilateral agreement there and your press release that followed on April 26, 2023? He said nothing. This is why we're having a lot of problem at the community level, because some of these leaders, I don't really know what they do. This morning I was up at 6 o'clock again, cooking breakfast at 7. And I don't really see a lot of leadership, but I hear a lot of complaints. So I really encourage the department to come and give me a hand, and maybe we can have a open house type information session. Thank you.
Minister Semler?
Thank you, Madam Chair. And I like I said, I would commit to, working with the member on what his vision is that he wants to have. If there's staff that we need to have a meeting, if it's involving the Leadership Council, I would suggest that the MLA, as well as myself, I can reach out to the Leadership Council. I would suggest that he work through his chair of the Sawtoo Regional Wellness Council to reach out, to work with her board if there is concerns, and maybe the next in-person meeting be in the Sawtoo. Those are what I would and if there is an in-person meeting in the Sawtoo with the Leadership Council, I would be more than willing to come.
Okay, thank you. MLA Yakalaya, do you have any questions?
Yes, I do, but I saw Robert's hand up. Robert has his hand up for a while, so do you want to just go to him?
Okay, Robert is alternative, but I'm going to the members first
Okay.
for the social
Okay,
development.
okay.
Okay.
Okay, thank you, and thank you to the team there for their presentation. It was very good, informative. The one question I had was, and remember, nurse who brought that up was the language. I know that it must be a barrier that having to work with that, especially with the lack of resources and stuff. What is the plan for the language part of this? Thank you.
Yeah. Minister Semmler?
Thank you, Madam Chair. Madam Chair, one of the areas that, that like we've said we've struggled with is interpreters. We have the like within the medical travel policy, anyone who doesn't speak English, is automatically given, it's one of the criteria for a non-medical escort to have if they don't speak English. And we do know that not just speaking it, but understanding, when like some people can speak English, but they may not understand the medical terminology. These are the things that need, when putting in requests, and I think sometimes this is what ends up happening is that there is a request for a non-medical escort, and then it'll just say language barrier or, needs interpreter or is an elder. And sometimes it just is an elder. And there's many scenarios where then we have a denial because it doesn't meet one of the criteria. And then we go through, have to go through, either they end up going to the MLA or they go through an appeal process. And more often than the appeal process is people just go to the MLA, especially from small communities. They know who their MLA is, they go to their MLA. And that's why I said, like, these kind of scenarios should not always be that. So one of the areas is we have to look at how we are, even our forms, when we look at our forms and we're sending the criteria, there needs to be an area where there has to be more information. And sometimes the letter from the doctor, like the doctors will write letters, but it doesn't fill in what is the criteria. So there's a lot, there is work that needs to be done in this area. As for interpreters within the hospital, I can, I'll put it to Joanne, because I know we have a team that works within Stanton, and then we have, every hospital has like a list that sometimes they have, but it's not, we don't have what we used to have years ago where we had a whole interpreter team. Madam Chair, I'll just let you pass it to the Deputy Minister.
Deputy Minister?
Thank you, Madam Chair. I think just to add to what the Minister had noted, we do have interpreters in all of our facilities. And there are times where, yes, we don't, particularly, let's just say, for example, Stanton, we may not have all the official language interpreters on site at all times. I think some of the challenges we do have is the time of day in which care is provided. So most interpreters do work during business hours, as an example, but we do have a supplementary service called Can Talk, whereby all of our health and social service providers are aware of that service. That does have, it has over 100 languages in it, so not just Indigenous languages. There's other languages that are available, whether it's Italian, Somalian, whatever it may be, that folks may need to access that service, and it's a Canadian-based service. But I would just echo the Minister's point around there are times where we don't have all interpreters for NWT languages available at all times.
Okay. Thank you. MLA Yakalai, do you have a follow-up?
Yes, I do. Thank you for that. Also, my question was the plan. What is the plan going forward to deal with the language issues? And also, I'm speaking from a small community perspective. Living in a small community, if you don't have the services at the health center, what happens? That's my question. Thank you. The plan, first of all, what is the plan going forward for languages for this anti-racism division and for small communities? Thank you.
Okay. Tim, you want to answer that?
Thank you, Madam Chair. One of the things that the whole system is approaching, it's actually a pan-Canadian approach to cultural safety collaborative, it's called. And one of the focus areas, actually, colleagues to my left here are leading it and helping to support the work in the NWT related to this collaborative, is focused on looking at the Indigenous wellness program that exists within the health and social services system, and how it's supporting not only inpatients but all patients and clients as they are receiving care. And one of the key early identifications, as Fraser mentioned in his presentation, was access to language services and being able to be heard and understand the care that individuals are receiving as they're going through our system. So I think as far as a plan approach, this is in its early stages of gathering information and doing engagement with various stakeholders related to the Indigenous Wellness Program. And through that, we'll be able to identify certain opportunities for improvement, both within the current program, but also across the organization as well too. So those are some of the early stages of plan. I don't know if anybody else at the table here has anything else to add to some of the early work that we've seen from that collaborative.
Okay.
Yeah, just to echo what Tim said, I want to say about just under a year ago, we began a journey, which Tim called as the Cultural Safety Collaborative. So we've been working with representatives within the 3 different health authorities, so the NTHSSA, Hay River, and the Clecho. And we had decided that we really wanted to have an opportunity to actively make system change. And so what the team had decided to focus on was the Indigenous Wellness Program, because that's a program that offers service to everyone from around the Northwest Territories. And we really felt that there was great work being done there, and so we wanted to dig in and do research and find out particularly what the staff at the Indigenous Wellness Program think. We're looking at ways to how do we build on the good work that they're already doing and innovate that program. And a part of the recommendations that are coming out of that includes, what do we need to do with interpretation, in terms of Indigenous language, how can we strengthen that? So that's one of the recommendations, as well as we'll have recommendations about many other things coming out in our final report. But we did engagement with the Indigenous Wellness team. We've gone to communities. We've went to every region in the Northwest Territories to do community engagement, and we also have engaged with system leaders and nurses and frontline staff to really find out what the needs are and where we can do better. So I look forward to that final report coming out.
Thank you. Thank you. I just want to let everybody know that we are pressed for time. So I just want to let everyone know that to shorten the questions and answers. I have one question. I know that we know that racism is everywhere, and the Indigenous people experience it the worst, or experience it the worst or the most, of the racism, especially within the healthcare system. So you guys, the department identifies cultural safety and anti-racism division, and you did identify that IG appoints and etc. But I just wanted to ask if the Indigenous government or organization are actually involved in the process, in this whole process, because racism this topic is very important, and it concerns everybody. So I just wanted to ask, because you put down evaluation of training and etc. So it's good, but I just want to know if the Indigenous government have any input in this whole process. Thank you. Minister Semler, I guess we'll start with you. Yeah.
Yes, thank you, Madam Chair. And Madam Chair, the Indigenous Advisory Body is the body that the department works with, and they are all appointed from the Indigenous governments. I can pass it over to Karen Blunenhall, as her department directly works with them. She can explain to you a little bit more on that relationship and how the Indigenous governments, that's their voice within that whole unit. Thank you.
Thank you, Madam Chair. Yes, so we have been working with the Indigenous Advisory Body since 2018. And since then, we regularly, so for the 4 meetings a year, present our work, and we present new work. And so when we present our work, we're seeking their feedback and guidance. Are we headed in the right direction? Where do we need to shift and make changes? So a good example of that would be the training, for example. So we delivered or put together a presentation, an overview of the framework, and they provided feedback around that. And we extended an invitation for all Indigenous Advisory Body members to attend our training. At the last meeting in April, we presented a draft patient rights and provider responsibilities. And so Fraser can add any more about this, but it was basically like a document that lists what the patient rights are and then what the provider responsibilities are. And there was overwhelming positive feedback about those, and the intent to share that with the system and patients and clients broadly. So folks are really understanding clearly what their rights are as patients. So that's just an example of some of the work, but like I said, every single meeting we present updates about our work, and we seek their feedback and guidance, and then we have a responsibility to provide any updates at the next meeting. And so constantly involving the Indigenous Advisory Body members about our work.
Thank you. The reason why I asked is because the Indigenous leaders are hearing a lot of complaints as well. So that's why I am addressing to see, like, I know that, there are some people appointed, but are they reporting back? So that's the only reason why I asked that questions, and it is important. So now I would like to move on to Julian. Do you have the questions? And I'll go to Mr. Hawkins as well. Thank you.
Thanks, and I'll try to be brief. Yeah, just kind of building upon a question that Mr. Testard asked at the start, just related to the number of locums, nurses, temporary staff who won't have access to training, and that the answer kind of spoke to finding ways to get people coming back so they receive training. But does the department have protocols in place which all medical professionals have to follow for patient care, which are targeted at preventing oversights related to a patient's inability to advocate or communicate for themselves? So whether or not it's kind of an issue of racism, just noting that this inability to advocate or communicate seems to be the root cause of a number of the cases where preventable negative outcomes occur. What protocols does the health department have in place to ensure that, if someone comes in and they may or may not have difficulty in advocating for themselves, are there ways that we can prevent that?
Okay, Minister Semler, want to answer that question?
Yes. Thank you, Madam Chair. And this goes to, I'm going to just speak from the heart now, because this is the whole being of the Indigenous patient advocate. For years and years and years, and I'll go back to my grandmother, when the nurse or the doctor comes in, you don't ask. That is the way that it was. I remember growing up and the home care nurse coming in and it's just like, here's your pills. And then they leave. And then she's like, I don't know what these pills are for. And then, you know, so it's because you don't ask. And so that is the way it was. And so this is where we are today. It's 2024 and we still have people who don't know that they should or could ask or advocate for themselves. We haven't lived in a system where we've been able to do that. You know, when we look back, it's only been 60 years since certain things that have happened. You know, it's only been 20, 30 years since the last residential school closed down. So people are still in that mindset that they don't get to ask questions, they don't get to challenge the system. And so providing Indigenous patient advocates who are Indigenous, who are somebody that they can trust, who they know that will advocate, that they can go to, because they don't know all of these locums and they don't know this doctor and they don't know this nurse. And I don't feel comfortable. So I'm going to go to you and you're going to work with me and give me the strength to go and ask those questions. So that is what that is there. And now we just need to build upon that.
Thank you. Thank you, Minister Sibler. MLA Morris, do you have a follow-up?
Yeah, thanks. No, I appreciate the advocacy program. So I guess the next question would be the level to which advocates can be available in any different place in the system. But maybe if I can be a bit more specific, like if a patient is being discharged from the hospital who has come in with a complaint and has maybe not even received treatment or has received a certain treatment, are there protocols in place to kind of have, before the patient leaves the hospital, to have kind of a double check or just to make sure that the care provided did address any potential symptoms or anything like that? Just noting that there's been a number of cases, even recently, where this has been a problem where someone has come in. So, yeah, I'm just wondering if there's protocols in place or there's protocols being developed to help to assist with this issue where people may or may not be able to communicate effectively what's going on, and that results in a misdiagnosis or a diagnosis simply not happening.
Okay. Minister Sibler, you want to answer that question?
Yes.
Or
Yes, thank you. And you know, and I hear them where the member is asking, and this is, I think this is that systemic change that we need. We shouldn't have to put something in place. Everybody should be checking and making sure. And we're not saying that they haven't been. And if there, you know, if there needs to be something, this is where I think this is where Fraser's the team comes in, that we figure out, and you know, working with the Karen's team, what those things are that we need to have in place. And that is the work, like in the presentation that in the beginning of the presentation, they both have said there's work that's been going on. They're gathering the stats, they're gathering the data, and now it's making that systemic change. It's that systematic change in the policy, and that's the work that's coming, and that's 2024 forward, you know, and these are critical things that need to be put into place. And if it is, you know, a checklist that we've checked all our boxes, you know, if that's where we have to be, then that's where we have to be. And you know, and I think that is the work that's going on right now, but they need the time. They're, like we said, they're a small team. They're a vital team. They're important. They're important for Indigenous health in this territory. I think we are, when we look at it, we are doing things that a lot of places aren't doing, and they need the time to do the work, you know. So as they're continuing on and gathering the data, they still need to make those, they need the time now to actually put those changes into place. And thank you.
thank you. I will now go to MLA Hawkins.
Thank you, Madam Chair, and just double checking everyone can hear me okay before I proceed.
Yes, we can hear you.
Perfect. Thank you so much. Appreciate the chance to ask a question. I'm not on this committee, but this is a very important topic, so I'll make sure I'm quick, precise and to the point, and certainly on topic. So I did go to the GNWT's website, and unless I was in the wrong spot, I saw the critical incident report information. It looked like it was only dated from 2020 to 2021. So either I'm in the wrong spot or reporting is delayed, and I'm curious if that's a policy challenge, whereas things aren't reported. Because of the nature of them, they're delayed. And that sort of leads me to the next part of the issue, which is how are they specifically communicated? Because, I mean, for people wanting change and to be, in other words, improvements, that is, we have to advocate for them and need them in a way that they're presented so people can understand some of the challenges individuals are facing, whether they're staff members receiving this or their clients, such as community people at large. Because I would find it very helpful that reporting was more timely and more specific. And when I mean specific is not necessarily generic examples by saying, well, X amount of people receive racism. I would like to be even more specific by saying, for example, X amount of people had received disrespectful or racist behavior, because that helps us define what the problem is and also help us become advocates for change. Because, I mean, we can't let this negative behavior exist, and certainly without the transparency of some value, it's difficult to advocate specifically to be part of the solution. And I'd certainly, no doubt, my colleagues in the room want to be advocates for the solution as well. So maybe sort of around the reporting and how it can be a little more transparent. Thank you, Madam Chair.
Thank you, MLA or Minister Simler. Yeah. Thank you.
Thank you, Madam Chair. And when we speak to critical incidents, those are the ones that we put on the website. But those can't be specific because they're usually about a specific client, and so they're usually the recommendations coming from a situation. But how do we report, and how do we provide those stats? Because the Office of Client Experience is fairly new, with Mr. Lenny's department, gathering the stats, but also under Ms. Blondin Hall's department, I guess where I'm at is questioning as to in the department. Maybe I'll pass it to Karen, and she, with how they gather and work within systemic racism in the system and the change. And I hear where you're coming from, Mr. Hawkins, MLA Hawkins, as to what these are. But I'll pass it to Karen, and maybe she can explain that a little bit better.
Okay, Ms. Blondin Hall. Yeah.
I can add that I'm on a working group for the patient experience survey, and we are looking at developing specific questions around experiences of racism. I'm sorry, I don't know when that is expected to be released. I think we're working through the questions this summer. But yes, that is a very important question around how do we know how we're doing with experiences of racism, and how are we counting those measures? Thank you.
MLA Hawkins, do you have a follow-up?
Thank you, Madam Chair. Just a very brief one. It is simply built around two areas, which is the Ombuds report gives specific examples of situations. And without pulling it up, I think the human rights also goes even further specifically to situations. Now, these end up becoming public processes, but I would encourage the department to come up with some type of more timely and more transparent way I'm not suggesting in any way, and to be clear, I'm going to repeat it again, I'm not suggesting in any way that the transparency level needs to be exactly the same, but, you know, every foot has a different size shoe type of thing, and maybe, you know, maybe something special needs to be accommodated for transparency on these, be it the incident number, the types of incidences, and sort of in a reporting line. And I would encourage the department to find a policy way through this. This is not about outing one particular individual. It's about tackling the system at whole. I have great faith that from the sounds of everything that it's being communicated amongst all the parties. So, I mean, the education level's there. But that said, the education also needs to be public, and for MLAs, including other community partners, to be advocates. I'll leave it at that. But we need to be part of the solution, and better reporting, decision reporting, complaint process reporting, things like that, for us to be all part on the same page of solution. So my point being, Madam Chair, as I finish off, is saying that I would encourage the department to find a way to mirror in their own way that fits them properly and appropriately in ways we do through the Ombudsman and Human Rights. That's all. Thank you, Madam Chair.
Okay, that's more of a comment. So, and then I just have one more, okay? And then we'll end.
Can I just,
okay.
Madam Chair, can I just respond to that? I think that's what Mr. MLA Hawkins is saying is exactly what the Office of Client Experience is compiling, is because up until now, we have not had that data. We, you know, the more root of it is going through your MLA. That's been where a lot of Indigenous people have gone to voice their concerns, and then it's been dealt with through the MLA's office and back down to the department, kind of like that route. So I think where the Office of Client Experiences and the Indigenous patient advocates now are gathering the data from Indigenous people on their concerns, because before they never were comfortable complaining. You know, we didn't have the statistics of people complaining. It's like in any of our departments, you know, if you look at where Indigenous people, it's like if they get a no, then it's walk away, and it's because they just become that they don't follow it up, because it's just I'm always being told no, so there's no point. It's that same sense. So I'm glad that we have this department, and when we have the data, I would be glad to share this kind of data so that we do see what's coming through this office and we do see the concerns. We also have to protect patient confidentiality. We have to protect health information. And so I understand where people complain into a process like the human rights under that legislation. But when we're taking on complaints and if there's identifiers, if the pool is too small, we can generalize the data. But I think the more and more that we're collecting the data, the better work that we can all work together to support this change.
Thank you, Minister Simler. We look forward to seeing the data as well, too. So, MLA, to start, do you have one more questions that you would ask?
Thank you. I will try. I have a few more questions, but I'll go quickly, perhaps. Under your slide, your presentation, you mentioned commitment standards that are being added to job descriptions. So is job performance going to be measured against the commitment standards that have been developed along the lines of a competency? Thank you.
Okay. So who would, Minister Simler?
I will pass that off to Ms. Blondinhall.
Okay.
Thank you, Madam Chair. And yeah, I mean, that is the core impetus behind it, is to have those elements structural built into the job descriptions and have them a part of their performance appraisals, a part of their core work, Madam Chair.
Shauna, MLA Morgan.
Thank you, Madam Chair. I had a question about the staffing levels at the Office of the Client Experience. There was a slide about this, but it was confusing, the explanation. I guess what I'm wondering is, are there vacant positions? It says that there are 8 positions filled. There are 4 advocate positions filled indeterminately. I didn't know if that 4 was part of the 8 or in addition to the 8, and then 5 positions that are core funded. Again, is that part of the 8 or in addition? And then somewhere else it says that you have no O&M core funding for the Office of Client Experience. So then I'm confused again because it said there's core funding. Can you just give us, or maybe this could be done in writing too afterwards, but I just wanted to get a sense of what are the position, like how many positions do you have? Are you having trouble filling some? Are there vacancies? Are you aiming to establish more? I know you're talking about establishing regional navigator positions. I'm just wanting to get the overview of how many staff do we have? Is it adequate? What are we aiming for? What core funding do we have or not? Thanks.
Minister Simler?
Yes. So the patient advocates are all within the Office of Client Experience, and that falls under NTHSSA. And then the department that with the under Ms. Blondenhall is where there's the 10 positions, and then the 8 are filled. That is within the Department of Health and Social Services. So she works within the department, and that team works within the department. It does not work within NTHSSA. So they are like the strategic part of the cultural awareness, and that is what they provide the work to the authorities. And maybe if you want, we can provide the kind of the layout of that in writing to committee.
Okay, so Kieran, did you want to add one more? Okay.
Thank you, Madam Chair. So the Office of Client Experience isn't an independent office. This is unlike the Patient Ombud in Ontario or the First Nations Ombudsperson Office in Saskatchewan, and these are developed specifically to advocate and receive complaints about the healthcare system in those jurisdictions. So there's a lot of good reasons, policy reasons, to have an independent office, given that you don't create binding recommendations now, you just create recommendations. Is there some value, or what's your perspective on independence versus being a part of the authority? Thank you.
Okay, thank you. Ms. Blondenhall or Minister?
Madam Chair?
Minister Simler? Yes.
Yes. We have an Office of the Ombud, and people can choose to use that route. Human rights, we have the Human Rights Commission. They can choose to use that route. This is an internal process to be able to advocate internally. And the reason why is, and it goes back to my, going back to the experience working within outside and trying to advocate as part of an Indigenous group, working for people, advocating for them, and collaborating with the health authority on the outside is a lot different than being an advocate inside. And so the patient advocates that are on the inside have access, and they can access information, they can access the client's information, they are free to be able to, navigate them through the system inside the health authorities. And so that is where the need is, and to get the immediate results. And so I hear what the member is saying on, but we, like I said, we do have the Ombuds office, and we have other routes already. We are a small jurisdiction. Our population is small. We're just trying to provide a space right now for people to be actually comfortable to be able to go to and advocate on their behalf where they're not comfortable doing that, and being able to bring that data forward for us so that we can use that data on those concerns and the issues that are being brought forward to make systemic change.
Thank you, Minister Simler. I think, can Tim answer that question as well?
Thank you, Madam Chair.
Madam Chair?
Yes.
What I would suggest is that within within this question that if we, we can go to the Deputy Minister to respond, and then.
Okay. Deputy Minister?
Thank you, Madam Chair. I don't have anything to add, just echoing that the intent behind the Office of the Client Experience is to affect change within our overall health and social services system, and we want that to be timely. I know that we've had a number of questions here. I noticed this evening about how can we do things quicker, more efficient, and of course more thorough. And having that office to be part of the health and social services system, that is our intent. And then externally, there are other mechanisms, as Minister has mentioned, whereby if folks do not feel that they want to bring their concerns forward within the health and social services system, there are other mechanisms to do that.
Okay, thank you. Thank you. Now, I want to thank the Minister and her official for joining us today. This concludes today's public briefing on systemic racism in the healthcare system. So thank you for coming and doing your presentation.